Hello, and welcome to Reducing the Global Burden of Cancer-Associated VTE, Applying Guideline Concordant, Evidence-Based Care, and Shared Decision-Making Strategies to Improve Patient Outcomes. My name is Khorana, and I'm from the Taussig Cancer Institute of the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University, and Case Comprehensive Cancer Center in Cleveland, Ohio. I'm pleased to welcome my colleagues, Dr. Robert McBain from the Mayo Clinic Gonda Vascular Center in Rochester, Minnesota, and my colleague, Dr. Dana Angelini, also from the Taussig Cancer Institute and Cleveland Clinic in Cleveland, Ohio. Before we move on, I would like to say thank you to Medical Learning Institute and PeerView for providing this session, and to the Bristol Myers Squibb and Pfizer Alliance for providing the educational grant for this web broadcast. Look out for poll questions we'll be posing during the session, and please ask us your questions by entering them in the space provided. Before we start, here are my disclosures, and I'll leave them up for a second. These are the disclosure of my two faculty colleagues, Dr. McBain first, and Dr. Angelini. Please note some disclaimers here about the planning committee and the content and peer reviewers and their financial relationships. And additional disclosures of unlabeled use and disclaimers are noted here. Here's the URL to download slides and practice aids, and also to apply for CME, MOC, and other credits by clicking the buttons located in the left-hand panel. And certainly you're welcome to join us in the conversation on Twitter at PeerView. So let me start off by talking about what we'll be discussing today. Our agenda is broken down for our three faculty, including myself, into three separate topics, all of which are very relevant to both treatment and prevention, and speak to the changes that are taking place in those areas. So without further ado, here's our first speaker, Dr. McBain, who's a professor of medicine at the Mayo School of Medicine, chair of the Division of Vascular Medicine at the Mayo Clinic Gonda Vascular Center in Rochester, Minnesota. And Dr. McBain will be speaking about the management of acute VTE in patients with cancer. Dr. McBain.
Thank you, Dr. Khorana. I'm really excited to be here and to present a very important topic to you all as the learners, and this is cancer and associated venous thrombosis. And the first question we should pose is, why should we be interested in this topic to begin with? And I think the numbers speak for themselves. First of all, there are nearly 2 million new diagnoses of cancer each year in our country, and of these individuals, 1 in 5 will develop a new venous thrombotic event each year. And this accounts for up to 20% of all the venous thromboembolism that we experience in our communities. And compared to individuals without cancer, cancer increases the risk of venous thrombosis by approximately 6-fold. We know that the incidence of cancer-associated venous thrombosis is directly related to cancer site-specific risk. And here is one of a number of tables of similar content showing you all of the various cancers and their associated risk of venous thrombosis. And the first thing I'd like to point out is that there's a broad difference, a broad range of thrombotic risk comparing the highest risk on the upper left to the lowest risk on the bottom right. Notice there's a 7-fold difference between, for example, colorectal cancer and brain cancer with regards to venous thrombosis risk. But even colorectal cancer, prostate cancer, and gynecologic malignancies carry a substantial increased risk relative to patients without cancer. And so venous thrombosis risk is cancer site-specific, and it's also stage-specific. Here are the stages 1, 2, 3, and 4, and you can see that the vast majority of events are occurring in those individuals with stage 4 cancer. And even compared to stage 3, stage 4 cancer carries about a 3-fold increased risk, and stages 1 and 2 up to a 7 or 8-fold risk. And so we know that, again, that it's cancer site specific. We know that it's cancer stage specific. And then we know that it's cancer duration specific. And so here is the odds ratio of venous thrombosis related to the date of diagnosis. And you can see that the vast majority of activity is occurring within the first 3 months, certainly within the first year. However, once you get beyond a year, that risk still continues and is above that of the normal population, and that really persists for the life of the individual. We know that it's cancer treatment specific. Here are some common agents that are used to treat various malignancies, and you can see that each of these carries an increased risk of venous thromboembolism. And we know that cancer-associated venous thromboembolism greatly affects survival. In this landmark study, patients with cancer and venous thromboembolism were compared to patients with cancer alone. And you can see that the probability of death is greatly increased for those individuals whose malignancy is complicated by a venous thrombotic event. So you might ask, why is this the case? Well, there are a number of acquired conditions or risk factors which contribute to the risk of venous thromboembolism in cancer patients. There's chemotherapy, there's cancer-related surgery, there's hospitalization for a cancer-associated treatment. And then we know that central venous catheters definitely increase the risk of upper extremity venous thrombosis, but it turns out because cancer-specific treatments are delivered through these catheters, there's also increased risk at other sites. So these are some common factors that patients with cancer will experience, and each of these increase the risk of venous thromboembolism. We also know that the cancer itself can be procoagulant through activation of endothelial cells, platelets, neutrophils, but also these very toxic inflammatory cytokines can increase thrombotic risk, and the cancer itself can be coated with tissue factor and can contribute tissue factor containing microparticles, all of which increase inflammation and increase the relationship to venous thrombotic events. So next, once we've now introduced the topic of venous thrombosis associated with cancer, I would like to then pivot to talk about treatment of acute venous thromboembolism. And for this purpose, let's talk about a very typical case that all of us have seen in our clinics. This is a 65-year-old male with a history of newly diagnosed pancreatic cancer. He's undergone a staging laparoscopic surgery and now has a port placed with the implementation of FOLFIRINOX. Several weeks after starting chemotherapy, he presents to the emergency department with dyspnea and chest pain and is found to have this finding on his CT scan. And I know that many of us are not radiologists, but on the cross-sectional images on the left, you can see a fairly large thrombus burden occupying both the right and the left main pulmonary arteries. And this is also depicted in the coronal views on the right. Well, a duplex ultrasound is performed before admitting this patient to the hospital, and you can see that in fact he also has a fairly extensive right lower extremity venous thrombosis, including the common femoral vein and the femoral vein. So now we have this 65-year-old gentleman with rather extensive thrombosis, and the question is, what would you do to treat this patient while you're seeing him in the hospital or perhaps even in the emergency room? On fractionated heparin, low molecular weight heparin, would you start a direct oral anticoagulant or start a heparin product and then transition to a vitamin K antagonist? And in order to unpack this patient, I think we first have to go back somewhat deep into history 20 years ago to review the CLOT trial. And you might ask, why in the world would we be going back 20 years to talk about a very old trial? And the reason is because this, in fact, is a very pivotal trial. And this is the trial that really sets the stage for all future trials in this space. And so the CLOT trial randomized 670 patients to either dalteparin as monotherapy for 6 months or dalteparin converted to warfarin. And the primary endpoints of this trial were symptomatic venous thromboembolism. You will remember that this was a strikingly positive study with almost a 50% reduction in the hazard ratio of recurrent venous thromboembolism with a number needed to treat of only 12. And you can see that this primarily resulted in a significant reduction in deep vein thrombosis with not such a big impact on non-fatal or fatal pulmonary emboli. And the beauty of this trial was that the use of monotherapy with dalteparin did not significantly increase the rates of major bleeding, and unfortunately, it did not seem to impact mortality rates. And so based on this trial, the gold standard for treating patients with acute venous thromboembolism and malignancy has been low molecular weight heparin. But low molecular weight heparin definitely has its limitations, including pain and ecchymosis at the injection site. Its cost can be prohibitive at $100 a day, even though enoxaparin is now generic. Thrombocytopenia, renal failure, bleeding can all be a complication of this form of therapy, making it less than ideal. And thus introduced into this space are the new oral direct factor 10 inhibitors apixaban, edoxaban, and rivaroxaban. And I would urge you to download this practice aid to learn more about the indications and adverse effects of the direct oral anticoagulants. Well, there have now been 4 trials in this space comparing one of the direct oral anticoagulants to dalteparin, and again, dalteparin because of the CLOT trial, the Hokusai trial, SELECT-D, the ATOM VTE trial, and Caravaggio. So of course, the comparator in each of these trials is one of the direct oral anticoagulants, but again, all of these trials compare their results to dalteparin. This slide shows the efficacy comparing the direct oral anticoagulants with low molecular weight heparin and dalteparin for each of these major trials. You can see that in the Hokusai VTE cancer study, the efficacy of edoxaban was numerically lower than low molecular weight heparin and dalteparin, though this did not reach statistical significance. In the SELECT-D trial, rivaroxaban was associated with a significantly lower risk of venous thromboembolism recurrence compared to dalteparin at 4% versus 11%. And in the ATOM VTE trial, there was a significant reduction of VTE recurrence for those patients receiving apixaban. In the Caravaggio study, the apixaban arm had a numerically lower rate of venous thromboembolism, which reached the non-inferiority cutoff. And this did not come at an increased risk of major bleeding. You can see that edoxaban in the Hokusai had a slightly increased risk of major bleeding, but SELECT-D, the ATOM trial, Caravaggio, all were not statistically significantly different compared to dalteparin. Unfortunately, this improved efficacy with essentially similar safety did not result in an overall mortality improvement, which was disappointing in each of these trials. So this begs the question, which would patients prefer? An oral direct oral anticoagulant, or would they prefer low molecular weight heparin? In the ATOM trial, this question was posed in the form of a satisfaction survey, which was given to patients each cycle throughout the course of the trial. And you can see in the rows are each of the 7 cycles. In the columns are the questions. In the blue, this is a significant improvement favoring the oral apixaban. In the red favors dalteparin. You can see that the vast majority of these survey questions favored an oral direct oral anticoagulant compared to an injectable agent. And we feel that this resulted in an improvement in premature discontinuation rates, which were significantly lower in those patients randomized to receive apixaban compared to dalteparin. Well, the next question is, of course, do the guidelines endorse this type of management of patients with venous thrombosis in the setting of malignancy? And the answer is a resounding yes. For each of the guidelines, the use of a direct oral anticoagulant would certainly be acceptable. The next question is a very important one and yet unanswered. And that is, what is the proper duration of anticoagulation therapy for patients treated with acute venous thrombosis in the setting of malignancy? And I can only say that there are a number of trials poised to answer this question in various stages of completion. So look for each of these trials to become available in the next years to months to years. So let's get back to our patient. Remember, he's a 65-year-old male with pancreatic cancer. And the question is, how would we treat this individual with rather large burden thromboembolism? And I think based on the data, that we could certainly consider the use of a direct oral anticoagulant because of its efficacy advantages and also its safety profile. And we would like to think then that an oral direct anti-10A inhibitor would hopefully improve compliance for our patients and reduce the need for subcutaneous injections. And so in conclusion, I think each of these trials have suggested that direct oral anticoagulants are as effective as dalteparin in the treatment of cancer-associated venous thromboembolism. We're going to hear more about bleeding complications in upcoming lectures, and I would pose that this is an important area of discussion. So next we're going to hear from Dr. Khorana, who is going to talk to us about risk stratification and primary prevention of cancer-associated venous thromboembolism, a very important topic. Dr. Khorana.
Thank you, Dr. McBain, for bringing us all up to speed on the latest data in the management of acute cancer-associated VTE, which is a rapidly changing space, and overall a win-win for cancer patients with new advances that both reduce the risk of recurrent VTE, are safe, and provide better options than in the past. Now, it's great that we've made so much progress in managing VTE, but wouldn't it be great if we were able to prevent it? And that's what my talk will be focusing on. Let me start off with a case also. This is the case of a 69-year-old woman who was initially diagnosed with colon cancer a few years ago. At that time, it was resectable. She had a resection and adjuvant FOLFOX for 6 months, but now presents with multiple new liver metastases and is starting on a new chemotherapy regimen of FOLFIRI, which is a combination of IFU and irinotecan with bevacizumab and anti-VEGF antibody. Her baseline labs at the time of starting are a hemoglobin of 12, a platelet count of 425,000, and a white count of 12,000. And her comorbidities also include obesity and hypertension. Her risk for VTE is therefore high, and that's based on the high platelet count, the high leukocyte count, and the high BMI, and I'll explain that in a second. But the questions to ponder as we discuss this is this somebody that we would recommend prophylaxis for, and if so, which drug would we recommend? Now, as is sort of amply clear to all of us taking care of people with cancer, there are multiple risk factors that predispose them to having VTE. Some of them, Dr. McBain already described. The type of cancer, for instance, pancreas and primary brain tumors are amongst the highest. Histology, adenocarcinoma over squamous cell cancer, the initial time frame, and so on. Some are treatment related, so things we do to cancer patients, major surgery, hospitalization, systemic therapy, and not just chemotherapy, but including newer agents, and in fact, even immune checkpoint inhibitors, central venous catheters, and even supportive care agents such as erythropoiesis stimulating agents or blood transfusions can all increase the risk. There's certainly patient-related risk factors, age, ethnicity. In the United States, African American patients are more likely to get clots than Asian American patients, for instance, and comorbidities, including obesity, renal dysfunction, and pulmonary disease. And finally, there's an emerging science of identifying biomarkers, including simple biomarkers such as components of the complete blood count that I just described, but also more complex ones such as tissue factor, p-selectin, and so on. About a decade ago, my colleagues and I published a risk assessment tool that brings together the 5 most important predictors of VTE into a score that can be clinically applied. It uses cancer type as sort of one of the primary variables, and if you have a high-risk cancer such as gastric or pancreatic, you get 2 points. If you have slightly low-risk cancers such as lung, lymphoma, GYN, or some GU cancers, you get 1 point. And for every other cancer such as breast cancer, or for this patient, colorectal cancer, you get 0 points. But you can also get to high risk by some of these other variables. So a high platelet count, you get 1 point. A low hemoglobin, you get 1 point. A high leukocyte count, you get 1 point. A high BMI, you get 1 point. And initially, we defined a score of 3 or higher as being high risk. This has been validated across multiple data sets. Dr. Angelini and I published a review of all of the different studies that have validated this risk score, which are up to 40,000 plus at this point. And in all of these studies, there was a differential in the risk of VTE for a score of 1 versus 2 versus 3 versus 4, and so on. And so higher the score, the greater the risk of VTE. I show here one of the latest validation studies that we just published in Cancer Medicine. Newer studies also suggest that although we had originally picked 3 and higher as a cutoff for high risk, newer studies suggest that perhaps the cutoff should be 2 and higher. This was first shown in the Vienna prospective study that first validated the risk score. And here, as you can see on the left, patients with a score of 2 or higher had a roughly 10% rate of VTE at 6 months, which most people would consider high. And this was confirmed in a large meta-analysis of the score in over 30,000 patients, 28,000 of whom had 6-month follow-up, where the rate of VTE was also around 9% at the 6-month time frame for patients with a score of 2 or higher. And so many studies, as we'll discuss for prophylaxis, have focused on this cutoff, 2 or higher, for entry criteria. In the decade since the study, our original score was published, there have been multiple new scores that have been proposed, some of whom have been validated. I list some of those scores here. They do have some advantages, such as an improved positive predictive value, but some of them have not yet been validated. The 2 most recent ones with the greatest data are TIC-ONCO, which includes genetic risk factors, and a score by Poppinger and colleagues from Vienna, which adds D-dimer and removes all other variables except the primary site. And this has now been validated and shown to have an improved positive predictive value. These scores have not yet been tested for predicting for benefit from prophylaxis, which of course is one of the biggest advantages of risk assessment. To learn more about these scores and to have links to be able to calculate those scores, please consider downloading this practice aid for additional resources on web-based implementation of these risk assessment tools. Now, how as a clinician can you apply risk assessment in 2021? There are actually several aspects to assessing VTE risk now in your clinic. Many cancer patients are unaware of the risk of DVT or PE in their course of illness, and so you could target high-risk patients to give them warning signs and educate them about the warning signs and symptoms of DVT and PE. And this was successfully done in a pilot project in Ottawa, where high-risk patients were given literature specific to DVT or PE. You can use it for screening, as we've been doing at the Cleveland Clinic. Most importantly, you can do it for prophylaxis, and that's what we'll be discussing over the next couple of slides. So what is primary prevention of cancer-associated VTE? It's considering the use of anticoagulants in higher risk patients for whom who have not yet developed DVT or PE, but in whom you consider them to be high risk and think about preventing it by using specific anticoagulation. This is not a new concept. Primary prevention of VTE exists in many other settings. I'm sure you're very familiar with primary prevention in the post-surgical settings, post-orthopedic surgeries, post-abdominal surgery, in inpatient setting for acutely ill medical patients, in patients with atrial fibrillation, and so on. And so there's multiple indications for primary prevention of VTE, but in the cancer population, there have now been 2 large studies that have looked at preventing VTE with DOACs. These are both published in the same issue of the New England in 2019. AVERT used newly diagnosed cancer patients who were starting a new treatment regimen with a Khorana score of 2 or higher and randomized those patients to either apixaban or placebo. And Cassini, which was identical ambulatory patients with solid tumors or lymphomas with a score of 2 or higher, also starting a new systemic therapy regimen, but in this study randomized to rivaroxaban, 10 milligram once a day versus placebo. Both studies were similar, with the exception that Cassini included a pre-randomization ultrasound, and if you had a DVT or a PE, those patients were taken out. And Cassini also employed screening ultrasounds while people were on the study, whereas AVERT focused only on symptomatically discovered endpoints or incidentally discovered PE on staging scans. With AVERT, the data are very clear. Placebo rates were 10%, as was predicted by the initial risk assessment tool, down to 4% with apixaban. That's a 60% relative risk reduction, a 6% absolute risk reduction, and the number needed to treat translates to around 17 or so, which makes it very easy to recommend. Cassini also showed a reduction in VTE, but because of the pre-randomization ultrasounds, about 5% of patients had a clot before they were even randomized and were taken out of the study, which may have reduced the power of this study to show that primary prevention works. Rates were lower, but not statistically significant for the primary endpoint, 8.8 down to 6%. During the intervention period, the rates were more solid, 6% down to 2%. That's about a 4% absolute risk reduction. And if you included secondary thrombotic endpoints such as arterial events, MI or stroke, the absolute risk reduction was even greater. Safety-wise, for both AVERT and Cassini, there was about a 1% increase in major bleeding. And that was true for both of these trials. So the number needed to harm is about 100 or so for both of these studies. As a result of these data, as well as in the context of prior trials of low molecular weight heparins, all guidelines have now taken to recommending primary prophylaxis, but only in high-risk patients. For ASCO and NCCN, these are defined as a score of 2 or higher, and the agents that are recommended are apixaban, rivaroxaban, or low molecular weight heparin. Low molecular weight heparin primarily based on the older studies, which had some risk-adapted post-hoc analyses, whereas for apixaban and rivaroxaban, you have prospective data. Same for the ITEC and ISTH guidelines, as well as for the ASH guidelines that just came out. So the guidelines are very consistent across the board. They've moved from a position of, oh, we don't know if primary prevention works, to a position of, yes, we believe it works, particularly in the high-risk patients. Don't recommend it to all cancer patients, but do consider it in people who have a score of 2 or higher and don't have contraindications to anticoagulation. Guidelines also recommend VTE prevention in the inpatient setting. So hospitalized patients with cancer admitted for medical reasons, so a pneumonia or other acute illnesses. And here, this is recommended by all the guidelines. And of course, for patients undergoing major surgery for at least 7 to 10 days after the surgery, and for up to 4 weeks post-discharge in people who are at high risk. And that's primarily people with abdominal or pelvic cancer surgery with certain high-risk features. How can we best implement prophylaxis in your practice? At the Cleveland Clinic, we've created an EMR alert, an electronic medical alert that automatically calculates the Khorana score, identifies high-risk patients, and then alerts the physician to say, hey, this patient is at high risk. Would you want to consider prophylaxis? And in Vermont, a recent publication showed that not only did they create an EMR alert, but then that led to a referral to a specific service, an anticoagulant service that comprised people with special interest in hematology and included pharmacists and advanced practice providers. And in a 2-year study, they were really successful in not only identifying high-risk patients, referring them to this consult service, but also in ensuring that appropriate patients receive prophylaxis. And in their study, for a sustainable period of 2 years, they showed that almost 94% of patients who were referred and were at high risk received prophylaxis. And so I think the field needs to move on from having demonstrated that you can identify high-risk patients to having demonstrated that prophylaxis works to how best can we implement this so patients are able to benefit from the results of these large, successful and well-done clinical trials. For this patient that we started out with, the colon cancer, with a patient with colon cancer and some risk factors, including a high platelet count, a high leukocyte count, and a high BMI, the calculated VTE risk would be at least 10% over 6 months. And so for this patient, certainly I would recommend prophylaxis. Your choice of anticoagulant agent could be either a DOAC or a low molecular weight heparin by some guidelines, although most would prefer DOACs because of the prospective clinical trials data that we just discussed, with either apixaban or rivaroxaban. So that's what's has changed in the recent couple of years regarding primary prevention and risk assessment of acute cancer-associated VTE. Both treatment and prevention obviously have to deal with the fallout of anticoagulant use, which is bleeding. And so to discuss bleeding-related risk assessment in patients with cancer and VTE, I'd like to now invite my colleague, Dr. Dina Angelini, who's an assistant professor in the Taussig Cancer Institute and the Cleveland Clinic Lerner College of Medicine here in Cleveland, Ohio. Dr. Angelini.
Great. Thank you for that introduction, Dr. Khorana. Thank you for the organizers and the supporters of this event to invite me to discuss bleeding issues in cancer thrombosis patients. This topic is important because cancer patients do have more bleeding events on anticoagulation compared to non-cancer patients who are treated with anticoagulation, on the order of 2 to 3-fold more major bleeding events compared to non-cancer patients. So to open this discussion, we will start with a case. We have a 61-year-old man with stage 4 esophageal cancer, currently on capecitabine. He presents with chest pain and new dyspnea on exertion. He's found to have multiple segmental emboli in his pulmonary vasculature. His history is notable for multiple brain metastasis treated with whole brain radiation. He has normal liver and renal function. He has no contraindication to anticoagulation, but he does live in a rural area without close access to a large medical center. So to open our discussion, what is his risk for bleeding associated with anticoagulation in this setting? Currently available bleeding risk prediction scores have been derived and validated in atrial fibrillation patients, and some of these scores include cancer as a predictive variable for bleeding. So the usefulness of these scores in the cancer population is limited. There are currently no cancer-specific risk prediction tools to predict bleeding. Several risk factors have been reported to correlate with increased bleeding in cancer patients, but these risk factors come from small studies with limited methodology. However, some reported risk factors include the following: extremes of weight, recent major bleeding, renal dysfunction, immobility, the presence of metastatic disease, surgical or procedural interventions, gastrointestinal or genitourinary tumor type, and thrombocytopenia. In our patient's case, risk factors are highlighted in red. So in our patient with esophageal cancer and brain metastasis, what would you recommend for the treatment of acute symptomatic pulmonary embolism? Option A, admit for heparin with bridge to warfarin, given he has brain metastasis and you refer an easily reversible anticoagulant in a rural setting. B, reduce dose anticoagulant given his inherent risk of bleeding. C, therapeutic dose low molecular weight heparin. Or D, therapeutic dose DOAC. Before we answer, let's review some of the data. In this new era of using direct oral anticoagulants for cancer thrombosis, there has been particular attention to higher bleeding rates seen in patients treated with DOACs in some of these trials. A meta-analysis looking at the 4 major landmark trials comparing DOACs to low molecular weight heparin is depicted here. And you can see major bleeding on top, and overall, there isn't a significantly statistically higher rate of major bleeding in the overall population in patients treated with DOACs versus low molecular weight heparin. However, the clinically relevant non-major bleeding was statistically elevated in patients treated with DOACs compared to low molecular weight heparin with a relative risk of 1.65. And bleeding from unresected primary tumors, particularly the GI tract, the genital urinary tract, and gynecologic malignancies were the most common sources of bleeding in these trials. In the same meta-analysis, data from the rivaroxaban and edoxaban trials specifically looked at the risk of major bleeding in patients with gastrointestinal malignancy. The top portion of this forest plot shows data from the gastrointestinal patients, and the risk of major bleeding was significantly elevated in GI cancer patients treated with DOACs compared to low molecular weight heparin, with a relative risk of 2.3. Conversely, patients with non-GI malignancies, the risk of major bleeding in patients treated with DOACs versus low molecular weight heparin was comparable. In this table, you can see the absolute rates of major bleeding in the GI cancer population, which was 9.3% of patients treated on DOAC versus 4% major bleeds of GI patients treated with low molecular weight heparin, and again, the relative risk of 2.3%. Our patient has the added risk of brain metastasis. We do know that certain tumor types have higher risk of brain hemorrhage, and these tumor types include melanoma, renal cell carcinoma, choriocarcinoma, thyroid carcinoma, hepatocellular carcinoma, and the malignant gliomas. Additional risk factors for intracranial bleeding include thrombocytopenia, underlying bleeding diathesis, coagulopathy, and recent neurosurgery. So what is known about the bleeding risk in patients with brain tumors? So current evidence suggests that secondary brain metastasis of non-high-risk tumor types and those with treated brain metastasis have acceptable bleeding rates with therapeutic anticoagulation. Conversely, in patients with untreated brain tumors and in patients with an increased risk of intracranial hemorrhage, an IVC filter can be considered. Understanding the high rate of complications from these filters is possible. So what do we know about the choice of anticoagulant in the setting of brain metastasis? Well, data are limited for all anticoagulants in the setting of brain metastasis, but several small retrospective studies have shown no difference in bleeding outcomes in those treated with DOACs versus low molecular weight heparin. One of the larger trials included 96 patients from an international retrospective cohort study in patients with brain metastasis on anticoagulation. The study suggested comparable safety of low molecular weight heparin and DOACs. However, it is worth noting the absolute 12-month incidence of intracranial hemorrhage remains high in this population. So back to our case. Based on the current evidence, I would suggest the preferred treatment for esophageal cancer patient with treated brain metastasis and acute pulmonary embolism to be treated with therapeutic dose low molecular weight heparin. So what if he has thrombocytopenia? So we have the same case, a 61-year-old man, stage 4 esophageal cancer with acute pulmonary embolism, but now on routine blood work, you find his hemoglobin to be 11 and a platelet count of 35,000. So how would you manage cancer-associated VTE in a patient with thrombocytopenia? Some of the options could include the following. A, you could admit him for IVC filter placement without anticoagulation. B, admit for heparin drip and close observation for bleeding complications, plus or minus the use of platelet transfusion. C, reduced dose of low molecular weight heparin. Or D, full dose DOAC with close outpatient monitoring of his platelet count. So in 2018, the International Society of Thrombosis and Hemostasis Scientific and Standardization Committee released guidelines on the management of cancer-associated thrombosis in thrombocytopenia. The recommendations include the following. For patients with acute thrombosis and additional high-risk features, therapeutic dose of anticoagulation with platelet transfusion support can be considered. And high-risk features include patients with symptomatic, segmental, or more proximal pulmonary embolism, proximal DVT, or history of recurrent or progressive thromboses. For a patient with lower risk event, a dose modification strategy can be considered in patients with platelet count of 25 to 50,000. And dose modification could include 50% dose of anticoagulant or prophylactic dose anticoagulant. And lower risk events were defined as those with distal DVT, incidental DVT, subsegmental pulmonary embolism, or catheter-related thrombosis. For patients with such low risk events and a platelet count severely low, less than 25,000, anticoagulation should be withheld with serial monitoring of the thrombus. Beyond the acute period, defined as the initial 30 days after acute VTE, a lower or modified dose of anticoagulation should be considered in patients with a platelet count of less than 50,000. And lastly, admission for an IVC filter should be considered on a case-by-case basis in patients with acute venous thrombosis who are actively bleeding or have severe prolonged thrombocytopenia for which anticoagulation with platelet transfusion cannot be achieved. So back to our patient's case, stage 4 esophageal cancer with presumed transient thrombocytopenia from chemotherapy. Of these options, I do think option B is reasonable. You'd admit for heparin with close observation with platelet transfusion to keep his platelet count above 50,000. And heparin does offer the benefit of easily reversible with a short half-life, and you can monitor him closely in the inpatient status. So there is a lack of prospective data on the management of thrombocytopenia in cancer thrombosis patients. Some data to look forward to include the MATTER study, which will report on the management and outcomes of antithrombotic medication use in patients with hematologic malignancy and thrombocytopenia. This is the multinational prospective registry of both inpatient and outpatient hematology patients with thrombocytopenia who are treated with anticoagulant and/or antiplatelet medications. The management will be solely at the discretion of the treating physician. Some other data that was recently discussed was at the American Society of Hematology 2019 annual meeting, where Held and colleagues discussed their data from a single institution center retrospective review of cancer thrombosis patients with thrombocytopenia before and after the ISTH SCC guidance I previously mentioned was implemented. They report that adherence to the guidance was excellent, and they reported a trend towards less thrombosis in the post-intervention period. However, they did note a trend towards higher incidence of bleeding. So future studies to guide management in this vulnerable population is clearly needed. So unfortunately, bleeding complications will arise in some of our cancer-associated thrombosis patients who are on anticoagulants. So I did outline some practical considerations when you find yourself with this patient issue. So you want to evaluate the site of bleeding and employ site control if possible. Options there would include things like radiation, surgical intervention if appropriate and feasible, or systemic therapy to control the site of disease. And of course, you want supportive care with platelet transfusion, blood cell transfusion, and other supportive care measures. You want to evaluate for modifiable risk factors for bleeding by checking coagulation labs, checking their basic lab work, platelet count. You want to evaluate for drug-drug interactions that may increase the risk of bleeding. You want to ask them about other medication use, such as nonsteroidal anti-inflammatories or other medications that can increase bleeding risk. And in cases of major bleeding, you do want to think about anticoagulate reversal strategies. Once your patient is stabilized, you may want to think about your class of medication and potentially altering your anticoagulant class. You could consider dose reduction after the acute treatment period. And as mentioned before, cautious use of IVC filter placement, which is primarily reserved for patients with acute thrombosis and contraindication to anticoagulation. To conclude, bleeding risk assessment and management in the cancer thrombosis population relies heavily on clinical judgment. There was an unmet need for research to develop cancer-specific bleeding risk tools and guide treatment. I will now turn it back to Dr. Khorana, who will review other key takeaways and conclude.
Thank you, Dr. Angelini, for a terrific overview on bleeding-associated risk of anticoagulant use, specifically in the cancer population. As we heard earlier today, there are paradigm shifts happening in both the management of acute cancer-associated VTE, as described by Dr. McBane, and new recommendations from guidelines for the use of direct oral anticoagulants in the primary prevention of cancer-associated VTE. Next, we'll move on to audience questions and answers. Dr. McBane, this first one's, if you could help me answer this one, can DOACs be used for treating cancer-associated thrombosis in patients with multiple myeloma? And for how long should we keep patients on anticoagulation, and what investigation should we do to monitor the patient's case?
Thanks, Dr. Khorana. This is an excellent question. And the essence of the question is, what about specific cancers? And can we use DOACs or low molecular weight heparin in any specific cancers? Is there good specific cancer data for management? And I don't think we're there yet, but I would feel very comfortable using a direct oral anticoagulant in a patient who has an acute venous thrombosis with the underlying diagnosis of multiple myeloma. I think in the future, we're going to be able to better choreograph this type of management depending on the specific cancer, but at this stage, we would be very comfortable using it in this condition. The second question of how long to treat is a very tough one, and we don't have good randomized controlled trial data to answer this question yet. In general, we would treat patients until they have no evidence of active cancer, defined by cancer evident on cross-sectional imaging or receiving systemic therapy for their cancer or radiation within the past 6 months, surgery within the past 6 months. And then what to do for monitoring these patients. The DOACs are super easy to use, and I think there's this tendency to give patients a DOAC and forget about them. That is not the case, and especially in cancer patients. We need to be monitoring these patients carefully for bleeding complications. We need to make sure that their platelet counts are acceptable, like Dr. Angelini has commented on. We need to know that the renal function is reasonable for these patients while they're on these medications, which can be renally cleared. And so these are the things that I would recommend for this particular case.
Great, thank you. And I didn't have time in my talk to address this, but myeloma patients, specifically those being treated with IMiDs, are particularly at risk for VTE. And there are separate risk assessment tools called IMPEDE or SAVED that can predict high risk of VTE in this population. And there is a well-defined algorithm for primary prevention in this setting as well. A second question here is about routinely giving VTE prophylaxis to all patients with cancer who may be at stage 4. I would advise against this. Certainly metastatic disease is a risk factor for VTE, but as we discussed earlier, it's not, risk is not dependent on a solitary risk factor. You have to have a combination of different factors to identify patients who are at high risk. So I think routinely giving it to everybody with metastatic disease, you could have patients with breast cancer or prostate cancer that are going to live for years and years with hormonal therapy. And certainly that population does not need to be on long-term primary prevention. So I would urge everybody to do it, what the guidelines say, which is assess based on the risk score, and then identify patients at high risk, and then consider prophylaxis for those not with no contraindications to prophylaxis. And then we have time for one last question. This one's for you, Dr. Angelini. Taking into account the results of the different trials on cancer-associated VTE, is there a different benefit amongst different DOACs, particularly regarding the GI bleeding profiles?
Yes, I think this is an excellent question, and we have to be careful when comparing the data because these DOACs have not been compared head-to-head with each other. As I mentioned in the talk, the meta-analysis specifically looked at the data from the edoxaban and rivaroxaban trials, which showed increased risk of bleeding in the GI cancer patients with those drugs. Looking at the ATOM, VTE, and Caravaggio study, there actually was not an increased risk of bleeding in the GI cancer subpopulation. But I think we have to be cautious. The numbers overall were small, and I think more data in this arena is needed before we widely recommend one DOAC versus another, particularly in GI malignancies.
Thank you for your attention, and thank you to our panelists for a great discussion. Please remember to complete and submit your post-test and evaluation for CME, MOC, NCPD, or CPE credit. You can also go to this URL here to download slides, the practice aids, watch a replay of the event, and certainly you're welcome to join the conversation on Twitter with the handle @PeerView. Thank you so much for your attention.